My dear students, in this video, I am going to discuss about an entity which was not considered that important a decade ago, but as with time, this has assumed tremendous importance and a lot of work is going on about its prevention and management strategies. So this is what is the title, that is post-intensive care syndrome, or PICS as we would otherwise call it. Now, post-intensive care syndrome, or PICS, describes a collection of new or worsening physical, cognitive, and mental health impairments that persist after surviving critical illness and ICU admission. And this is one of the reasons why the survivors of critical illness fail to move into the mainstream. And even after recovery from their illness, they remain handicapped for quite some time. And they require necessary treatment, attention, support whatsoever, and rehabilitation strategies, of course, to bring them back to the streamline on the mainstream. Now, this syndrome affects an estimated 50 to 80% of all ICU survivors with at least one domain of impairment. There are three domains, and the symptoms with which they present can last from months to years following recovery. And that is why their contribution in the society for that time is markedly reduced or impaired. And therefore, it is very important to necessarily treat those patients during these times. Let us start with this case. The case presents a 60-year-old female who is evaluated 8 weeks after ICU discharge following severe pneumonia, which was complicated by ARDS at septic shock. And she demonstrates the following manifestations across the three domains. The first domain, that is the physical impairment, where she presents with profound generalized weakness, which requires walker assistance. Two, with limited ambulation of maximum of 50 meters. ICU acquired weakness with 3 to 4 of the maximum of 5 in strength in the extremities. Significant muscle wasting and a total of 8 kg weight loss. Barthel index decreased from 100 to 65. I can tell you what it is in the subsequent slides. The second domain is the cognitive impairment, where she has a MoCA score of 22, which is abnormal. I'm coming to MoCA score as I'm going to highlight them. Deficits in attention, delayed recall, and executive function. Difficulty concentrating and managing previously routine tasks which she used to perform quite well, and complaints of mental fog and forgetfulness. In psychiatric domain, she presents with moderate depression with a HADS depression of 12, moderate to severe anxiety with a HADS anxiety of 14, post-traumatic stress disorder symptoms with a PCL5 of 48, with nightmares and flashbacks, and of course with sleep disturbance and avoidance behaviors. So all of these point towards a syndrome that is, we label it as post-intensive care syndrome. Now, these are the three domains, and I will just elaborate on those domains. Like physical impairment, in physical impairment, that like the patient of our case was having, there will be muscle weakness and ICU acquired weakness. There will be profound fatigue and deconditioning. There will be decreased mobility and functional limitations, shortness of breath, chronic pain, and sleep disturbances, often leading to insomnia. So all these impairments, if the patient is not presenting with, this needs to be asked, and actively they should be looked for in the presence of other impairments. Next are the cognitive impairments. So these are the battery of impairments which may be found in variable degree in a survivor who is having PICS. Memory loss and forgetfulness, attention deficits and poor concentration, executive dysfunction and problem-solving difficulties, slowed mental process, along with confusion and delirium. In regard to the third domain, that is the psychiatric or mental health issues, depression is the one which is most common among the survivors. There will be anxiety disorders in many, post-traumatic stress disorder with nightmares and unwanted memories in some, and decreased motivation is also something which is nearly present in all the survivors with Pics. Now, if we have to pick up these impairments systematically, we will require some scales. And these are some of the consensus-based assessment instruments which have been found to be important while diagnosing these patients. Now, when we talked about physical domain, the top three tools that one needs to use are the MRC sum score. MRC, we all know, is the Medical Research Council sum score, and this evaluates the muscle strength in 6 bilateral muscle groups along a score of 0 to 60, with scores of less than 48 indicating ICU-acquired weakness. The second physical domain score is the Short Physical Performance Battery, or SPPB, which assesses the standing balance, gait speed, and chair stands all along a 0 to 12 scale, with less than equal to 9 indicating impairment. And the third physical tool for physical domain assessment is the timed up and go, or TUG, which measures time to stand, walk 3 meters, turn, and return. And in this also, a time of more than 20 seconds indicates severe impairment. So these physical domains needs to be examined to figure out which are the impairments of physical domain that the patient with Pics is having. In cognitive domain, as I told you, the MoCA, or which is Montreal Cognitive Assessment, which is the gold standard screening tool, which is measured along a scale which varies from 0 to 30, where more than 26 is normal, whereas 18 to 25 stands for mild impairment, and less than 18 severe impairment. So comprehensive neurophysiological testing should follow abnormal MoCA results whenever the results are less than 26, including trail making test, Hopkins verbal learning test, and Stroop test. So although these are psychological tests which are performed in clinical psychologists, but good knowledge of these tests are also essential to the physicians so that the interpretations of the test results can become easy for them. In terms of mental health domain, when we look into the consensus-based assessment instruments, there are 3 top tools, which number 1 is the HADS, or the Hospital Anxiety and Depression Scale, with 2 7-item subscales, one for anxiety, one for depression, of 0 to 21 each, where 11 to 14 indicates moderate severity. There is a PTSD checklist for DSM-5, which is called the PSL-5, with a 20-item measure, again along 0 to 80 scale, where a score of more than 33 suggests PTSD diagnosis. And the third is Pittsburgh Sleep Quality Index, PSQI, which assesses the sleep quality along a 0 to 21 scale, and a score of more than 5 indicates poor sleep state. So these are the 3 top tools in mental health domain as per the consensus by. So there is 3 in the physical, 1 in the cognitive, and 3 in the mental. So these 7 tools are very important in diagnosing Pics. In addition to that, we also have to measure the activities of daily living, which we call ADL. And this is where is the Berthel Index evaluates the 10 ADL activities along a scale of 0 to 100, where 61 to 90 indicates moderate dependency. And also the quality of life. In quality of life, EQ 5D5L, this indicates 5 dimensions which are rated on a scale of 1 to 5, plus visual analog scale of 0 to 100. So these are, in addition, the instruments which can be helpful in the proper assessment of the Pics once we diagnose them using the other scales for knowing the severity. So the diagnostic algorithm in patients with Pics involves identifying the at-risk ICU survivors, screening for the risk factors, establishing baseline function, systematic screening at discharge, and 3, 6, and 12 months post-discharge using these validated tools, comprehensive evaluation if the screening is positive, establishing Pics diagnosis with temporal correlation, grading the severity, and last but not the least, screening the family for Pics F or Pics family. So the risk factors which the patient needs screening for, the key risk factors includes prolonged immobility, use of sedation for long duration, use of mechanical ventilation for long duration, lengthy ICU stays, systemic inflammation, and medication side effects. In addition, there are certain factors. So these are the additional factors which can lead to a preponderance of Pics, like female gender, lower education level, pre-existing disability, and the use of sedation and analgesia in the ICU. When we talk about Pics family, we have to remember that the family members of ICU patients can develop post-intensive care syndrome F, which experiencing adverse mental health outcomes, including sleep deprivation, anxiety, depression, complicated grief, and significant caregiver burden. And this can happen even when the patient has survived or even after the patient has passed away. So Pics F should be assessed using the HADS, Hospital Anxiety Depression Scale, Impact of Event Scale, that is IESR, that is revised, and Zarid Burden Interview. These are all the validated measures for to determine Pics F for the all close family members of the patient. The preventive strategies, there are certain evidence-based preventive strategies, and which includes limiting deep sedation and minimizing immobility or bed rest, early recognition and treatment of delirium, attention to sleep hygiene during the ICU stay, early aggressive physical and occupational therapy, which plays a very pivotal role in the early stage of the illness, where it can even cure it to 100% without any residual, and focused efforts on maintaining self-care, hygiene, adequate sleep, and nutrition. And most of this can actually be started early so that they don't progress into the stage where Pics is diagnosed. So they can actually start as a preemptive treatment also in those patients who have high risk. Regarding treatment and management, it requires multidisciplinary interventions, physical rehabilitation and therapy to improve the strength and mobility, particularly the muscle strength. Many of these patients are sarcopenic. Occupational speech therapy for daily function and communication, cognitive behavioral therapy and psychotherapy, which required especially in neurological patients, medication management for pain, anxiety, depression, and insomnia, again, an invariable accompaniment in all critical illness patients, pulmonary or cardiac rehabilitation whenever necessary. The support resources includes post-ICU follow-up clinics, which can help identify morbidity and arrange appropriate management, with involvement of physical therapists, dietitians, clinical social workers, psychiatrists, psychologists, speech therapists, as may be the requirement for that particular patient. When we talk in terms of long-term outcomes, the ICU survivors with Pics face higher risk of death in the years following discharge, and also a poorer quality of life in comparison to the matched controls. And approximately one-third of employed ICU survivors experience negative impacts on their employment, and Pics has substantial financial consequences for these patients, their families, and for the society through increased healthcare utilization. So the take-home message would be Pics is diagnosed when ICU survivors develop new or worsening impairments in physical, cognitive, or mental health domains that persist beyond hospital discharge. Systematic screening at 3, 6, and 12 months post-discharge using consensus-based tools like the MRC Sum Score and SPPB for physical assessment, MOCA for cognition, and HATS plus PCL5 for mental health should usually suffice. High-risk ICU factors predicting Pics development should be identified early and includes prolonged mechanical ventilation of more than equal to 7 days, delirium, benzodiazepine sedation, septic shock, and immobility requiring proactive intervention. And Pics family approximately affects 50% of caregivers and requires independent assessment using hospital anxiety depression scale and caregiver burden scales, as family outcomes directly impact patient recovery. Thank you very much.